All right, good morning, everybody. We're going to go ahead and get started. Once again, we have our colleagues from the Division of Neurology visiting us at Medical Grand Rounds today. But before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. So I should have said neurology as well as the Department of Biochemistry. So I'm delighted to introduce, first of all, Dr. Zaeem Siddiqi, who's professor in neurology in our department at the University of Alberta. After obtaining his PhD in neurobiology from Boston University, he completed a neurology residency and fellowship in electrophysiology and neuromuscular disease at Duke University. Dr. Siddiqi has established a comprehensive clinical translational research program in myasthenia gravis and an autonomic laboratory funded by Canadian Foundation for Innovation. He's been an investigator in several seminal clinical trials in myasthenia gravis and led the first clinical trial for sub-Q immunoglobulin. He has served as an examiner for the Canadian Congress of Neurosciences, the American Academy of Neuromuscular and Electrodiagnostic Medicine, and American Board of Psychiatry and Neurology. And I know he's got a very comprehensive list of myasthenia patients because we often see him on the wards coming to help us out with those patients. And then Dr. Richard Fahlman is a friend and colleague. He's full professor in the Department of Biochemistry and the current chair. He's director of the Alberta Proteomics and Mass Spectrometry Facility. He obtained his PhD at Simon Fraser University and completed postdoc work at UBC, Northwestern, and University of Colorado. Their current research is focused on biomarker investigations and mechanisms of protein synthesis and protein degradation. Aspects of these two diverse research areas have continued in their role in commercial development, including their role as CEO for Decipher MedTech and as CSO for E3 Therapeutics. So I'm delighted the two of them are collaborating this morning to talk about myasthenia gravis from bench to bedside, redefining diagnosis and treatment. Over to you.
Thanks, Nameet, for that introduction. And first, I'd like to thank Richard to accept this invitation to present with me. We have collaborated for close to about 10 years now, and we're excited to share the results of this collaboration. But the last time I presented at this forum to the Department of Medicine was about 8-9 years back, I think, on myasthenia and some of our other projects. And so much has changed in those last 8 years that it's hard to keep track. I'll be talking about myasthenia gravis. And before going ahead, here are my disclosures. As Nameet mentioned, I've been investigating a number of clinical trials, particularly for these novel therapies. None of those associations are relevant to today's talk. So I'll be talking about the clinical aspects of myasthenia. I'll be talking about some of the, referring to some of the past treatments, but mostly I'll be talking about the novel therapies which have come around, and particularly in the last 5 years. And I'm also very excited to share a landmark trial which has come, just published in Nature last week, which has the scope of changing the landscape in myasthenia. And then in the later half, Richard will be talking about our collaboration. We have been deeply involved in biomarker research in myasthenia, which is a key area of interest across the world. And he's got some exciting news to share with you today. So it's a collaborative talk. It's a lot of it being compressed in hopefully in 40, 45, 50 minutes or so. Clinical summary for myasthenia. For this audience, I don't need to. I'll just briefly mention that it is an autoimmune disease mediated by antibodies and causes severe muscle weakness, which is variable, can be mild, just involving the eye muscles, ptosis, droopy eyelids, or double vision, or it can be generalized, causing difficulty in swallowing, chewing, breathing. Many patients end up in the hospital because of severe weakness. About 20% of patients with myasthenia will have a myasthenic crisis where they'll require intubation. it's a very satisfying disease to treat because once a patient does well, he does very well, he or she. But then there are 15 to 20% of patients which keep us awake, which show up in the hospitals and they don't respond to it. Those are refractory patients. They don't respond to 2, 3, 4 immune therapies, and those are the patients which are really which we struggle with. Long known the serology. We have three kinds of antibodies in myasthenia. There is some clinical correlation with these antibodies. About 85% are seropositive, either with acetylcholine receptor antibody or anti-MuSK, and rarely anti-LRP4 antibody. That's true for generalized myasthenia. Ocular myasthenia, we've got nearly 50% of patients positive for antibodies, and we get a lot of referrals from ophthalmologists who are struggling to make a diagnosis of myasthenia because they don't have the key serum biomarker, the antibody. Epidemiology is slightly changing for myasthenia. Close to about 12,000 patients in Canada. It's a bimodal. I don't see the point over here, but it's a bimodal peaks, younger women and older males. And there's increasing incidence of myasthenia, particularly in elderly, and we are seeing more and more older patients. Just some very basics of the disease. The neuromuscular junction over here on the right hand side, the normal neuromuscular junction, where acetylcholine is released at the terminal and then transported across the terminal, the cleft to the post-synaptic membrane. And if I can get the pointer on that would be helpful, but I can't, seems to be here it is. So we can, and then the acetylcholine binds to the receptors and causes depolarization, entry of the sodium. Antibodies block this transmission. They bind to the receptors, cover the active sites, or they can cross-link the receptors, cause internalization of the receptor. Most commonly, and the most effective destruction method is this complement activation, where the complement cascade is activated and the membrane is destroyed. I'll come to that in a second. The diagnosis of myasthenia is mainly clinical. If you can think of the diagnosis, then it becomes easy to diagnose. The diagnostic delays take place when patients, the myasthenia is not on the horizon. It's the diagnosis supported by, of course, nerve conduction EMG studies. Sensitivity is about 70% for Rextin for generalized myasthenia. Single fiber EMG is an advanced technique. I think if I have to guess, probably 15 to 20 people in Canada do it. It's an extremely intense way to diagnose myasthenia, only in those patients who don't have antibodies, but it's a very high sensitivity. And finally, of course, antibodies are highly specific. They're very rarely false positive results in myasthenia. If the antibody is positive, it's likely that the patient will have some issue with neuromuscular junction transmission. Okay, the management over the years, I mentioned I'll refer to the past. I love this graph, and George, who's a colleague here sitting, the myasthenia treatment evolved and over the years. And I want to, if you look at 1930s, when neostigmine came in, it was actually a resident who described neostigmine, and his staff laughed him off that this is not a neuromuscular junction. And lo and behold, that neostigmine was given a trial 3 patients, and it was published in, I think, New England Journal, those 3 patients. It was a medical resident who first described neostigmine use, and then after that, the bottom graph, the orange graph, is the mortality. You can see rapidly reduced due to mechanical ventilation. But more importantly, steroids came around 1960s, and that really changed the disease course. But of course, they've got horrendous side effects. And then steroid-sparing agents is a thiopurine, cyclosporin, which is used commonly. You know these agents. I won't delve on them. And IVIG is extremely useful treatment in our hands. But what I want to point out is over here, after 85, all the way to 2010, nothing much. This is the time around where I went into med school and then started, and there was nothing much coming up in myasthenia. For about 20-25 is the lull period. Mycophenolate came around, the trial was negative. We used it off-label. But right from 84, 85, and then going on to up to early 2000s, there was nothing in myasthenia, new treatments, which have dramatically changed in the last 5 years. Also, all these therapies, the problem with these therapies was the drawback was they take a long time to work, 1 to 2 years sometimes. And you have to try one agent and then the other agent after 2 years tell the patient we have to switch, it's not working. It's quite delayed efficacy. Of course, toxicity was a problem, hepatotoxicity, nephrotoxicity, so on and so forth. There are a number of limitations with these older medications, though they have been a backbone of our treatment in myasthenia for the last close to about 50 years. Myasthenia, the challenge these I mentioned, is because not only diagnostic delay, but each patient is different. No two patients are alike, and that's why it's called a snowflake disease. When a patient shows up just with ocular symptoms to me, I can't tell that patient what the disease will be like in 1 year to 2 years. They may remain ocular, 10% to 15% remain confined to ocular, but most generalize and then generalize. But we won't know that they have a bulbar involvement, liver involvement. So it's a very heterogeneous disease. And that's, we don't have ways to predict a course of the disease. And we hit and try. We follow a pattern of treatment and we follow that till something works. So it's hard to manage because of that. And we are the challenges here in Alberta. And when I showed the slide, when I was presenting at US Center, I showed the slide and said, oh, wow. So look at it. So I've got patients up. You see the top star in Kagluktuk, Nunavut? I've got two patients, a young girl from Kagluktuk, right up there, Nunavut. So it takes days to get to, and these disease changes frequently. It's a specialized disease. It's hard for GPs to manage. In fact, most MG patients are managed at the tertiary care centers because it requires a lot of team effort. And so we've got these challenges because of our geography. Not only that, when I came, IVIG was only given in Edmonton or major hospitals, which is a backbone of our treatment in early myasthenia, and so on and so forth. And so we've got a lot of challenges in myasthenia managing here in Alberta. I would show a couple of things we did over here differently, which have helped us and delving into the past. This is the rituximab initiative. When I came to Alberta, rituximab was just being used, starting to be used in myasthenia, particularly anti-muscle myasthenia. It's got several advantages, rituximab. It has got a long duration of action, so patient go in remission long term and you don't require monitoring. So I felt that for long distances, it'd be useful for our patients who were not unable to do labs so frequently and long remission. So I thought maybe we can use it to STAT program. But the problem was that none of the treatments at that time, the guidelines included rituximab. They were case reports, whatever. And you can see this is a Matt Margioli, author on the is a major figure in myasthenia. You don't see rituximab in that list of medications. And this trial on the right side, neurology trial, was published in Neurology, came out negative. And it was a flawed trial, but it made our life difficult. When I would go to STAT, they'll say there's no indication. And we didn't have biosimilars available at that point. Now we've got biosimilars. So we produced our own data and were able to convince STAT that no, it is effective in our patients. And at this time, based on that, they allowed the use of rituximab. We did modify our dosing, and the biosimilars came, and now we got one of the largest number of patients on rituximab in the country, actually. When I present at these conferences, and they look at me and they say, wow, we can't get rituximab, but we were able to convince our STAT program based on our own data to allow it. The IVIG, I told you the IVIG was, when I came, it was only available in major centers. And this is our backbone, myasthenia exacerbations, new diagnosis prior to surgery. Patients have to come all the way down, stay here for 5 to 7 days, 3 to 5 infusions, and the wait time is several weeks to get to the infusion rooms. So I collaborated with Bruce Ritchie in hematology. He was using subcutaneous hemoglobin at that time for hematology, for immune deficiencies. IgG deficiency, and the subcutaneous hemoglobin is very concentrated, 20%, but he was using 2-3 grams. These are minuscule doses. We use hundreds. 2 grams per kilogram is our dose, which is 75 kilogram versus 150 grams. And heavier patients like myself will go out even higher. You see, so to give that amount of IVIG subcutaneously was difficult. So we came up with our protocols, worked with Bruce Ritchie, set up the infusion sites, and were able to narrow it down. The dosing pattern, you can see the center, smaller towns, we were able to start SCIG. And we published our first ever trial in myasthenia in SCIG. This is an old story now. The first time ever it showed actually you can give IVIG immunoglobulin under the skin at that dose. 1 liter of fluid under the skin, it's a big deal. Anyway, so based on that, we helped Vancouver and Calgary to set up their SCIG programs, and we have expanded to other centers. We have looked at the dosing. We have compared. This does not require more doses, much better tolerated. If you see, the side effect profile is much better as well, and patients love it because they get it at home every 3 months. They get the supply and they infuse it themselves. So it's been quite successful. So these are stories of the past. Where are we going forward? And in the last 10, 15 minutes or so, I will just look at what's happened what's coming. And this is where I want to put emphasis. A number of therapies over the last 20 years have been tried. I'm not going to go in details. Upstream, starting from the T lymphocytes, going down to B cells, and then plasma cell, a reduction of antibody, targeting the antibodies, and then, of course, the complement at the bottom of. So there have been a number of targets for new therapies discovery. And here we are right now as we speak. Just the last 5 years, these are therapies which have come around. And good news is we are one of the few centers where patients have access to these therapies. I'll share some of those with you. So starting from the top of the, again, I tend to lose my pointer. Here, so starting from the top, B cell directed therapy, rituximab was the first, but inebilizumab has just come around. Last year, the trial came out positive. It's going through approval process. The long-active therapy, very effective. The second class is the complement inhibitors. 3 of them, all 3 we have available. We'll talk about them. FcRn receptor inhibitors, the neonatal FcRn receptor. Again, 3, efgartigimod, rozanolixizumab, and nipocalimab. Highly effective agents, and they work on the antibody levels. And finally, and most importantly, the CAR T cells. They just came last week, and we are part of this, and I'll share this trial with you in the next few minutes. Here are the FC receptor and neonatal FC receptor inhibitors. What they do is the neonatal FcR receptor is involved in recycling of immunoglobulins. It's present on the endothelial cells, and it's a protective for the IgG. And if it is blocked, the IgG is destroyed in the lysosome. So FcRn receptor inhibitors prevent this recycling of IgG and lead to rapid reduction of antibody levels. I mentioned 3 agents, efgartigimod, rozanolixizumab, and nipocalimab. All 3 are effective and now available. In short and long-term studies have shown their efficacy. Here's what they do. You can see, and this is within 3 weeks of infusions, you get about 60 to 70% reduction in the antibody levels. This is similar to plasmapheresis, by the way. If you look at 5 cycles of plasmapheresis, which they reduce the antibody level by about 70%, 65% or so. So by just IV infusion, you can drop the antibody level to about, within 3 weeks, to about 65 to 70% across the board. And this is mirrored by the clinical response. MG-ADL is a well-known outcome measure, Myasthenia Gravis, active daily living score. You can see this is within 2 weeks, you see the improvement in scores. It ranges from 0 to 28, and there's a rapid reduction in clinical scores across several cycles, you can see. So the effect is maintained, clinical effect, cycle after cycle, the effect is maintained. There's a pros and cons to this cyclic approach. You have to keep giving the infusions. It's a cyclic dosing, but very effective. Here's our own data. This is from last year. I've got more patients on this now. This is not just my patient. We've got our colleagues who are using this. You can see the MD-ADL scores. The patient support program, I don't know whether you're familiar with, these are programs where patients get these infusions at their home. So the pharma companies, they allow till the drug is approved, and they allow the patient to get this free of cost at their homes. Then their nurses go and they do the assessment and whatever. So very useful for the patient, for us to be able to give these drugs to patients, allow the access. We've got 4 patient support programs in Myasthenia right now, which is the highest in the country actually. Mike Nicole was telling me from Ontario. They've got 3, some people have 2. We've got 4 programs right now. And so this is the efgartigimod program. The first one came around, and I won't delve in too much. You can see the patients. These are patients who have mostly not responded to other therapies. So we choose these patients, handpick these patients. Not everybody is sent for these programs, just to let you know. These are patients who have not responded to other therapies. Let's switch to complement inhibitors in a few minutes. Complement inhibitors have been well known. They, on the right, you see the normal neuromuscular junction. On the top, in the bottom, you see complement deposition. They destroy this membrane. You see, don't see the folds anymore. There is the receptors are lost. It's a major destructive pathway, the complement activation. And complement inhibitors, you can see on the right side, again, here's a if you somehow that it goes off. On the right side, you see the graph, the P dose, and within 24 hours of giving a complement inhibitor, the levels tank, the C5, these inhibitors target the C5, which is the rate limiting step in the complement cascade. So within a day, 24 hours, you can see a rapid reduction in complement levels, and they're only effective for, by the way, ECHR positive mice. They're not anti-vascular myasthenia. There are three of them approved: eculizumab, ravulizumab, and zilucoplan, which is subcutaneous. More and more emphasis on subcutaneous route, even for FcRn inhibitors. Patient can self-infuse. You don't require IV infusion. In the next 2 to 3 years, you'll see all these agents, and most of these agents switch from IV to sub-Q forms because, of course, of convenience. And there are two novel ones coming, cemdisiran, which is we were part of this. It's very effective. 3 of our patients who got on the trial, and all 3 are doing very well in the long run. They are refractory patients. Gefluzumab is a subcutaneous, another subcutaneous coming up. Just quickly showing the clinical data for Altomres or the refluzumab, rapid improvement in within days to weeks in the ADL scores in the short term on the right, and on the long term data you see improvement there. So, and this is for zilucoplan or Zilbrist, subcutaneous daily injections, and you can see the short term improvement as well as the long term persistent improvement with this drug. So very promising. Here's our own data from patient support program. I won't delve into that, but we get more and more patients going on complement inhibitors who are refractory to other treatments, and we are seeing some positive change there. Finally, coming to CAR T cells, I'm really excited to share this with you. So you in medicine know what CAR T cells are. They are targeted therapy. They are targeted lymphocytes against malignant hematologic cells like leukemia and lymphoma. They use a viral vector to reprogram the T lymphocytes, and they're reinfused in the patient and target the malignant cells. The issue with these therapies is they're highly toxic, and we know their side effects. They can be, the dreaded cytokine release syndrome, the neurologic side effects. So it's quite effective but toxic therapy. So it's the first time ever this has been tried in myasthenia, and this was just published last week. This trial in Nature. We are part of this trial, and this trial, the compound is Descartes, which is a targeted, which has got B cell maturation antigen, BCMA antigen expressed by plasma cell and plasma blasts. So later in the antibody production, these are the targeted therapy for plasma blast and long-acting, long-lived plasma cells. And the advantage is it uses messenger RNA, not a viral vector. So there's no virus involved. It's a messenger RNA programmed cells, so you don't require chemotherapy, and the toxicity is much less. Here are the trial results quickly. You can see these seropositive patients, rapid within 3 months of initiation. It's a weekly infusion or 6 infusion. You get a response, which is quite significant. And not only that, the response is maintained over 12 months, which is not seen before. 12 months, and the response is quite deep in the sense that about 33% of patients becomes asymptomatic. 1/3 of patients becoming nearly asymptomatic. That will last for till 12 months is huge. So it's something big, and hopefully there'll be more coming, but this was just, I thought, hot off the press. We're proud to be part of this trial, and hopefully this is going to pan into something big. So there are a number of advantages and pros and cons in novel therapies. Of course, they're very expensive, and hopefully with biosimilars coming in future, we will be able to access these therapies more. But right now, the patient support programs are our lifeline for many of our patients, and we are happy to be able to support them. We definitely need something better to help our management of myasthenia. As I told you, it's a hit and try. We don't have indicators to upfront choose the right therapy. We try and find the right combination of therapies. Sometimes I've got patients who are taking 3 or 4 therapies, unfortunately. And so that is the problem. And we don't have ways to predict the treatment response and the disease severity and so on and so forth. So about 10 years back, I delved into biomarker discovery, and I worked with my colleagues here. Went across the road to basic scientists. I collaborated with multiple people. One of them, of course, Richard, and we have been. A number of areas have been explored. We have been more involved in metabolome and proteomics, and we have been able to show some positive results. I won't steal the thunder from Richard, but we have been able to show some very promising biomarkers, and I'll let Richard take from here, and then we'll chat at the end of his talk. Thank you.
Yeah, so Zaeem said he would start exploring into biomarkers because this is where our story starts. This is sort of the current status of the autoantibody testing that's used, and it's just showing the sort of sensitivity and specificity, and as Zaeem already alluded to, it's not that great. And so and that's why we met years ago in the cafeteria, many meetings, and things like that. And we started this initial he wanted to go in proteomics. I was only involved in proteomics, not as metabolomics, etc. And we were like, where do we start? So we did our very small pilot study using proteomics, including another control group, another autoimmune disease, because we wanted to negate other things that are due to general inflammation and stuff like that. And this was sort of the initial team, a PhD student in my lab, and a postdoc with Zaeem. And I'll try to go quickly. I'm going to keep it light, but just to remind you, we do proteomics. Basically, we take blood sample, get proteins, we're going to digest it into peptides, analyze it, get all the data, and we're going to do comparisons. So that I'm a mass spectrometrist. So we did that study, and this is a quick summary of the data that we had generated. This is a 3-way plot. Each dot is a protein, and they moved to different points according to where they are. So we were interested in the proteins that were higher in myasthenia and not in rheumatoid or control. And we had stumbled upon these proteins here for some reason, which is, again, I'll come back to that. This was a peculiar observation because this is serum. Fibrinogen should have been gone. And I will come back to this story. And then, but with that pilot study, we needed to validate these findings on a larger study. So there's another kind of mass spectrometry we use. That first one, we use shotgun, look at everything. This is where we tune the machines to get very accurate measurements on very particular proteins very rapidly. This is a figure from our paper, and this is just summarizing how we do it. We get the parentine of each peptide that we're targeting and all the daughterines when we fragment it, so we know its exact chemical composition and the monitoring. So it's very reliable, very accurate. So we got versus just a readout like an ELISA. And then this is, again, I'll go through this quickly because this is all published. And then we did a larger follow-up study on a larger patient cohort, and this was all found. And in this group here, so this wasn't just the anti-acetylcholine positive patients, but there were some seronegatives in the cohort after it was unblinded to us, and anti-MuSK. So all the patients were showing this high signal. But I think, I can't remember the particular numbers. For us in the audience could probably give us how many were the ocular type. I think it was actually a third of them or something like that. And this is that group that usually is 50% negative on the autoantibody testing. So this was quite remarkable. We threw together from this smaller data set a receiver operator curve, which would give us very good results. And then the bottom is sort of showing you the sensitivity of the tests that Zaeem already referred to earlier in his talk there. So this was very promising. So that's why we sort of wanted to move forward. And again, but fibrinogen and serum, this is sort of weird. So it's sort of, they shouldn't happen because these people don't have coagulation disorders and stuff like that. But serum is prepared on ice, and as Fahlman showed here, so they only see this weird lack of, not complete lack, but this reduced fibrinogen cleavage on ice. So it's more of an in vitro artifact where we're seeing an enzymatic assay, because when he does it at room temperature, warmer temperature, it doesn't work. So it's we're seeing this, there's something happening in this, and then we're going to return to that. But I want to go back a little bit into blood proteomics. Blood proteomics is really hard, especially when I started, when Zaeem actually approached me, he was like, we're not going to find anything. And the reason is this, is the dynamic range of proteins in bloods is truly astronomical. I use this in my teaching labs, 10 orders of magnitude from things you're interested to in the whole range. And that's equivalent, 10 orders of magnitude is the number we can see, But what does that really look like? So for example, I showed you what a 10 orders of magnitude magnification would look like. On the bottom is an insect eye. You can count lenses. And if you had a telescope or a microscope with 10 orders of magnitude, you'd be on the moon and you could count those insect eyes. It's astronomical distance. For example, big telescopes in space, Hubble and all that, they're 10 to the 4. The electron microscopes have a 10 to the 6 magnification. There is no technology that does 10 to the 10. So it's a challenge to get through. So we sort of got lucky. For example, if we do straight up proteomics, like the study, we had similar numbers. We actually only conduct about 400 proteins in blood, even though we know there's many more because of this challenge of things getting in the way, and blood is so complicated. And they're showing you here the proteins ID up to 400 something. And this is sort of the ion intensity, which is the ion current we're seeing. So it's basically a readout of abundance. And if I take how many proteins make up 90% of the signal that we see, it's only 37 shown here in this Ferroni plot. It's not very interesting. And so you have to get lucky to see changes here in a clinical situation. So that's so more recently now, we started paying more of attention to protein corona. So there's emerging technology out now is proteins are sticky. They stick to all sorts of different chemical surfaces. Almost every different chemical surface will stick to different kinds of things. And it's sort of in some ways it's a challenge. What we're going to see can also be a benefit. Actually, it's very hard to find chemical surfaces that don't actually bind many proteins. And that's one of the reasons why DuPont made so much money on Teflon. Teflon is one of the few chemicals that's actually very good at that. And we find if you take different kinds of chemical surfaces, they bind to different groups of proteins and stuff like that. So they get what's called a protein corona. There's hard coronas and soft coronas. I'm not going to go into detail, but soft coronas you can wash off. Hard coronas, we can do whatever we want. We can't get rid of them. Only we can digest it with proteases to see what was there later. And so there's what you can do is if you actually take a chemical surface, dip it in the blood, see what sticks and pulls it out, you can actually help deplete that dynamic range and start seeing new things. As shown here with a simple bead assay, compared to this experiment I showed you before, if we take one simple bead model, we can actually increase our coverage quite quickly by just using a nanobead, which was actually pretty impressive. But you can get more complicated and start using different kinds of chemical surfaces and mixtures and figure it out. There's a company in San Diego we work with that actually has been putting a lot of effort into all those different compositions and things like that. Does it work? So we tried it with them before we did a big study. So we compared our blood versus we actually have to do 2 sets of beads because there's mixtures, because obviously we can't have beads that are all positive charge with beads that are negative charge because they'll just stick together and cause issues. So they got these proprietary mixtures. And now we can go from like 400 proteins in this sample to about 4,000 plus and things like that. So it's like for the first time in the last 24, 36 months, we can now start seeing deeper. And this has sort of come out after our initial study. So with this technology, we actually partnered with Seer, Zaeem, and a whole bunch of other clinicians I'm going to acknowledge later. We got a bunch of patient samples coming from this group showing up here, because all the clinicians we work with all have a reason why seeing stuff in blood might be of utility. So this was my biggest clinical study ever. Almost was 300 patients, but some we had to remove because after going through clinical charts, there was some misdiagnosis and different things like that. But it's so what did we see? As sort of summarized here in those Veroni plots, they're very, very different now. Albumin's in there, but it's tiny and things like that. So now you can see on the list, and we have a data set of now over 7,000 proteins, over almost 300 patients. The data, it's maybe not quite as good as 7,000. Some of the measurements are harder or noisier than others. So if we look at the CVs of this, so this is 1 over CV, so a high number is good, very accurate measurements. We got 2,000 proteins that have CVs that are quite good out over 300 patients. There's probably better data in here too, because proteins that change largely in the different groups are going to be in this high air because they're not the same. They do change in patients, but we just did this as a quality control before delving forward. So this is the first time we started going more deeply. Can we see new things in Myasthenia. So here's those 289 patients. You can see things really start to jump out now and things that are happening in, say, in this case, the myasthenia patient. There's a couple lower. I'm not showing you stats because they're so astronomically small. It doesn't when you have powers of this size. But for me, this is the first time, instead of proteomics, just hoping you get to see this protein, that protein, we can actually start looking at the data seriously. Let's go back to fibrinogen. It's like, here's a clotting cascade. I made sure I talked to Bruce Ritchie. This is the most appropriate one to use. So, okay, here's our fibrinogen again. The data is compressed. I'm not showing scale bars. The beads do with the sampling. You don't get the changes are actually bigger than we measure because there is that compressing of the data under measurements, which is actually good. So if you see a difference, if we validate it, it's probably going to be larger. So we can see that. But now this is the first time in my career I can take a pathway like that and just, we can see them all. And they can ask about each of these individual proteins, what changes or not. And they're like, oh my God, now we're starting, thrombin was a little bit lower here. Maybe this is not enough to cause a clotting disorder, but on ice, we start to see it. We can look at other clotting things involved in clotting factors, reaching out a little bit more, look at heparinase, another one we see in the blood. It's starting to make sense to us. We haven't digested all this. This is all too new. I've been working with Fraz and stuff. We're starting to think about these kind of things. And then now our colleagues can ask us questions about stuff. Zaeem, as we heard, he's interested in complement now. And so they can take this whole complement cascade, and we start looking at those. And I think Fraz came to us and said, can you see which ones of these, because they're interested with the new therapies, are the complement factors changed much in the patients? So we can go through, some are higher, some are lower, most of them not as significant as fibrinogen, but we're actually can now get a grasp of there are some minor changes. So I'm going to focus on one of them. Zaeem was mostly focused on the C5, but I'm going to highlight the ones in the bottom right. So complement 7, when we talk about membrane attack complex, yes, it was a little bit lower, and that was statistically down, but it didn't jump out at us. Now, hopefully, your eyes go to one of our control groups, is primary progressive multiple sclerosis. That C7 is much higher, and so it's giving us some interest there. So here's all the proteins in the membrane attack complex. This is the protein complex that eventually forms, that can penetrate membranes, part of the cell killing and everything else that's causing a lot of the devastation. One disease here has actually jumped out of us with the primary progressive multiple sclerosis. Relapsing remitting is beside it. We're starting to see signatures that separate the two multiple sclerosis groups completely. So I'm going to segue a bit away from MG a little bit now. We'll come back to a little bit where we're going. But we start to see those kind of changes, but maybe they're not great enough for diagnostics. But I think for me, even though some of the complement inhibitor trials for primary progressive multiple sclerosis failed, but they believe there was actually they don't penetrate the brain very well. And so, but there may be hope the complement targets might be pursued with multiple sclerosis if they can penetrate the blood-brain barrier well and get good delivery there, because it might be a huge one. There's a lot of points in the literature suggesting that complement is important for multiple sclerosis and during the neuronal damage. But we can do even better than that. We get for diagnostics. I can't show you the proteins yet because even my collaborator hasn't seen the list yet, Carlos in Calgary. But I can take a set of 5 proteins and go through, make a panel. And this isn't even a well-defined panel. We actually just did average weighting. There's actually better math to separate them, but we're going to actually come up with better algorithms with validated data. And I'll come back to that in a little bit. But we can actually start doing this for all those diseases in the group. I work with Glenn Jickling. We can do this. We got different protein panels for ischemic stroke and things like that. We can actually see now and pick out things. We still got to validate them, but our ends are so big, we're hoping it's going to be positive. For this kind of data, I could have give you an area receiver operator curve, but anyone that does receiver operator curves can tell that with the data separated this cleanly, the receiver operator is a square. There's actually no separation. But we'll see if this holds up with validation. And so that's trying to keep us on time to get early. So it's like very exciting time right now. And so we're moving forward on lots of avenues. We have right now this Myasthenia Gravis, working with Zaeem. We're trying to we're partnering with Adept and stuff. We would do a clinical trial with the clinical labs here with our new diagnostic. We're trying to deal with some caveats in blood collection because it's not really an endpoint assay with fibrinogen, where it's an enzymatic assay. So there's some handling issues we're trying to tweak out and verify before we ramp up those final trials. With Glenn and Carlos with the stroke and PPMS. We're going to do the validation by PRM like we did the fibrinogen. This allows us to do many proteins in parallel, but you still have to go through the work and validate all our programs and make sure the mass spec can see the individual peptides. An example here is from one of my students last week. So this is, there's actually raw data there in that middle spectra. This is a PRM curve of a peptide we're verifying. And boy, I didn't have the labels. If you look at the bar graphs left and right, when we do this, we test the ion signature on 2 different samples. The left is a control, the right is a stroke. I think for this particular peptide, we're seeing these huge kind of changes of this acute stroke. And we're seeing this for most of them, but I'm not going to go through all those particular things. So it's actually very exciting. Glenn already has, they're trying to organize, he's got them in his lab, but we don't have the sample. He's trying to get our cohort design for his follow-up trial. So it's really exciting. So we're waiting on that because I think we have all our PRMs ready. We have already in our lab, it's already received primary progressive cohort from Calgary. We're going to move ahead on that to make sure we can go on that. And for the other people, if they're in the audience on the line that are also part of the other diseases, we have similar data. I just don't have time today to go through it. Rheumatoid, every disease we look, we found something. Even between rheumatoid arthritis, seropositive and seronegative, we have markers for that now. So I know Walter's actually, hope we can be excited about that. And in parallel, like the clinicians, Zaeem comes to me, he's like, or do any of the markers correspond to severity of disease? They might help us, stuff like that. So we are doing a lot of regression analysis in parallel with different ones, because that's a big issue too, because if there are any that correlate with that, they could be actually used to help monitor treatment or maybe be used in clinical trials and things like that. So it's all very exciting. And so moving forward from that, it's like, I think there's lots and lots of opportunities. You know, these advances in serological proteomics, my title's cut off, it's been unprecedented. This is the last 2 years. This is like, to me, it's sort of like driving my, with proteomics 5 years ago is like driving my grandpa's Studebaker car to now jumping into a Ferrari. Like it's the technology changed so much. So it used to feel like a haystack. Thought Elaine might be here, but that's a terrible picture of a haystack, but that's what Gemini gave me. But now it feels like we burnt down the haystack to find, but now we find so many needles, we don't know what to do with the needles now. It's so like that because the ends are so large. But I want to spend a couple minutes. We have to acknowledge the key people. In my lab on the left, Richard Long and Shelley Braun are PhD students. They're doing a lot of the data analysis. Bernard is a research associate doing the handling, coordination of these projects. Down in my alumni, Yasser and Guru. Guru is part of the initial fibrinogen study. He's actually a clinical trial coordinator in pediatric oncology now. Yasser is actually in Toronto becoming clinical biochemist, clinical chemist fellowship. And all these other collaborators. Faraz in the audience here, he's started with the project, he's still part of it. Bruce Ritchie for all our conversations on this fibrinogen clotting and everything else. He's been a fantastic one. Jack is my mass spec guy. Ling Wang Kong, I don't know if you know him, he's fantastic to work with. He's a CRC chair in machine learning and AI, so he does all our machine learning algorithms and things like that for our newer stuff moving forward. OJ is my, we both do proteomics, we do a lot of stuff together. And then with relapsing remitting multiple sclerosis, Jason Plemmel, Chris Power, Greg Blevins, helping get us samples, interpreting data. Walters for the rheumatoid, Glenn for stroke, and Carlos for the primary progressive out of U of C. He hasn't even seen any of this data, meeting him after FEC. Hopefully he's going to be very excited because we already have the samples for, we're going to start the final study. And this fellow. This is Zaeem. Zaeem is one of the people, if I look back, one of the few people in my career who has actually changed my entire, has changed my career. He's the catalyst. I was always skeptical about serum proteomics because it was terrible. I could see 100 proteins. It was useless. And so Zaeem is actually, I have to acknowledge, has in the last decade, if I hadn't met him, my career would have went in a different direction and stuff like that. And so this is a picture. I remember I got this. I was on my way to work. I was on the LRT. Zaeem told me, we need to do pictures. I can't remember what the event was for. And I was like, I was dressed in, it's actually an old boys. We get, used to play rugby, and I have an old boy rugby team. And these are t-shirts we get made up when we travel. This one is about inclusivity because we've got all sorts of animals there. Like, we don't care who you are. But because I was going to go work on the mass specs that day, like, oh, picture day. And I was, he didn't tell me. And so that was, I've been poked at a lot with this picture when it was published everywhere around, but it's a fun one. But he was a big player in my career, and it's been fantastic working with him. And so everything that, if we find stuff in stroke and everything else, this guy's also just as responsible. So that's sort of the, yeah.
That last slide I was expecting, but thank you so much for the acknowledgement. But truly, it has been remarkable knowing him, and you can see how many collaborations have ensued, because we started 10 years back. You're right, when you went to him looking for, just finding something, that was 10 years back, and now you can see all our colleagues, not just from the neurology, but from neurology and so on and so forth. So thank you so much for
that. It's been fantastic.
We've squeezed 2 talks in one, and you can see we're both rushed because we have so much to share. Myasthenia is rapidly changing. Clinical side as well, and from the translational side, there's several new therapies coming. I could have spent just on just one class of drugs the whole talk, but I just wanted to give you a screenshot of all what's coming. Really excited about the novel therapies, the CAR T cells coming, which has been is a great time. So a lot of optimism going future. The therapies which is coming around the last 5 years, and the field is exploding right now. So thank you so much for your attention. Any questions from? Yeah, please.
Well,
go ahead. Yes,
before we move forward,
please.
first of all, I wanted to thank you both, because this, I think, is a great statement of what the faculty is trying to achieve with interdepartmental collaboration that we try and hear so much about. And this is, I think, a great sort of, example of where that collaboration can happen between the basic and the clinical. So thank you so much for that. I'm going to actually take chair's prerogative and just jump ahead. And, we got, no, go ahead. This is for you, actually, Zaeem, you showed this nice trajectory of the needle in the haystack to actually seeing those needles. And I wonder, because this is predominantly a clinical audience and online, Zaeem, in terms of these the biomarkers that we're talking about, where do you see things moving forward? I mean, you've talked about, you asked about whether or not you can predict severity of disease. Are you thinking more in terms of diagnostics? I mean, I've always historically thought myasthenia, we do pretty well with diagnostics. Yes, there's, still that room within the sensitivity curve and so on. Or are you thinking more in terms of personalized treatment plans? And where do you see this going?
Yeah, so 2 aspects to that. First of all, diagnosis. Yes. If you've got antibody diagnosis, simple. But I showed you the current delay is about 1 to 2 years. We don't have a bedside test, first of all. Richard is trying to develop a bedside test, a dipstick test. So this will lead to a dipstick bedside diagnosis, first of all. So we are looking at rapid diagnosis, bedside. So that will, and also patients who are seronegative. Patients with ocular myasthenia, 50% are seronegative, and about 15 to 20% of genital myasthenia is seronegative. So not only that, and so it will really help in early diagnosis, and we are hoping to get a bedside from that side. So that's the one advantage, but that's not the only thing, diagnosis. We are also hoping that these markers, which we are describing, and there are lots of work going on like in inflammatory biomarkers. And AI will be something down the road where we'll come with these sort of different biomarkers coming together to predict the disease course. It won't be one biomarker. I don't expect one biomarker will someday describe the whole extent of the disease, but with collaboration with other biomarkers from different areas. That is the future. And with AI collaborating different biomarkers, finding different complement of proteins or other biomarkers, metabolomics, to find different. So it's a rapidly evolving field, and I expect that this to not only impact their diagnosis, but also clinical care. But there's time. We have set the ball rolling, and as I said, there are other investigators doing the same work in different areas, and down the road, this will come together.
That's amazing. I mean, I just actually finished in Emerge seeing a patient who is a potential stroke, but we're going to repeat the CT, and there you go. Your biomarker would be very handy in those situations, right?
So you showed a nice slide of the demographics of patients being diagnosed with myasthenia, largely older adults. The mean age of people in the CAR-T trials was 56. The mean age in ADAPT was 46. So how are these treatments and these proteomics relevant to people who actually have the disease?
So you from the age perspective?
Yeah, so these treatments are all being tried in younger people.
Oh, yes.
They work in older adults. If you look at older adults, how does that affect you?
Yeah, so we got what I showed you this spotlight. The trials include all we got quite a few trials with these the younger patient population. The trial are a bit skewed because many of these patients are not doing well on other therapies, so they are a bit skewed toward more resistant patients. And the second is younger women who have potential to become pregnant. So those naturally are hard to enroll the trials. But having said that, most trials have got the average range, you're right, in 40s and 50s conducted. Reason being that many of these patients are refractory to other treatments over the years. We've got participants who have had disease for 10 years, 15 years. So that's why it's a bit skewed towards older patients. But having said that, now with the safety and with more experience, we've got younger patients on these therapies as well. I've got younger females trying these therapies because we have to delay their pregnancy plans. They're not doing well. And we found these to be safe in younger women as well. So I suspect that they will be used in patients, these therapies designed for patients who are refractory to other treatments. CAR-T cell therapy is quite an intrusive therapy. But in patients, if you see a patient who's not doing well in myasthenia for decades, they will, when we screen a patient with that trial, that patient was on chronic plasmapheresis for 15, 20 years. So those kind of patients, where do you go for them? And so I think that's where the field is going, looking at more serious patients, till we start using as routine therapies. Go ahead.
Yeah.
Richard, I think if I was going to Las Vegas and betting on biomarker discovery, fibrinogen would not have been high up on my list of things that I would expect.
It was terrible.
A beautiful ROC curve. So can you help tie together why this very non-specific acute phase reactive that also is probably impacted by therapies for MG like plasma exchange somehow boil out as the most beautiful end of the curve.
It was terrible. I remember.
That's a struggle.
Yeah, our first group meeting, I think Braz and I were there. I think we were like, we think you guys got plasma from the patients and serum controls. We were like, we didn't believe it at all. We actually made these guys go back, redo it. We thought they made a mistake or record keeping, and they proved us wrong. And then we did this little mini blind study where they didn't know the samples and they got 100% hit rate and stuff like that. So it was incredibly wrong. And even when we were publishing, we didn't know the mechanism. But now it's starting to look like all the other changes in myasthenia that we're starting to see a slight drop in thrombin and heparinase. Like I think now we can finally start to make sense of it all. But yes, this was the worst thing ever to find because no one would, it was hard to believe. But it's such a big signal because it is an enzymatic assay. These small changes leave a big difference in the kinetic rates and stuff like that. So that's all I can give you right now. We haven't looked into the effects, like why is thrombin a little bit lower? I think it has maybe due to the weird inflammation going on. It's like, why is it all the autoimmune diseases only attracting way up? So we're seeing a different response in these patients that are unique to the other autoimmune diseases. So that's good question. I don't have a full answer for you yet, but I like the analogy to the Vegas thing.
Maybe a follow-up technical question to that. So you've linked like a decrease in thrombin level. Have you tried inhibiting thrombin, pulling it down? I mean, there's a drug to thrombin that hasn't really taken off so much called the Bigatran.
For in what aspect, just to see if it's there?
Just see if a decrease in thrombin could give rise to the phenomenon that you described.
This residual fibrinogen? It's not really increased. It's just like fibrinogen and plasma is much, much higher. It's after you do the serum treatment, it drops low, but it's still much, much higher than what it normally goes. It's the trajectory. Because if we actually showed fibrinogen from plasma, I think in our paper, Fraz shows that there's so much fibrinogen in plasma, you can't even see it in the myasthenia patient. You got to remove the plasma and compare. It's a dynamic range issue.
I was just wondering if depletion or inhibition of thrombin if you try, like, could it give rise that? I mean, if you just did a control.
Oh yeah, we could possibly do that. I think these guys haven't known about the Thrombin issue till just recently, so we haven't had a chance to go over and design the experiments. But now with this stuff, there's lots of new things we can do to validate and follow up our initial study. So that's a good point, so that we could for the in vitro assays.
Peter.
Thanks very much. It really is going today. Just a good question in terms of clinical practice. So the neonatal FC receptor interference, do you find that leads to problematic hypoalbuminemia?
So yes, we are monitoring that. We do monitor the albumin levels. Slightly reduced, but not significantly. So we've got quite a few patients. The data I showed you are about 13 patients, but we've got many more now. We're close to about 40 patients right now on the novel therapies. So we are monitoring the novel therapies. We are finding, but albumin has not been an issue so far. Yes, mild, but not because the same receptor also involved in albumin metabolism. So, but not a huge. It was looked carefully in the trials as well. It showed subtle, but not clinically significant. Good question. Anybody else, guys?
Alrighty. Well, just on behalf of the department, thank you to you both. This was really, it was a great sort of enlightening and opening of the mind in terms of where things are going. So thank you so much.
Thank you very much.
Thank you. Thank you, guys.
Thank you for coming.